Good afternoon, everyone, and thanks for joining in today. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual Grand Rounds, updates in COVID-19 and monkeypox. And as always, I'd like to especially thank our sponsors, the California Health and Human Services and the California Medical Association. Next slide, please. These are our disclosures for today. Next slide, please. And this is our agenda. Next slide, please. As a reminder, CME is provided for our educational series, and you'll be sent a survey after the completion of the webinar where you can attest to your attendance. After you complete the survey, we'll send out your certificates. Next slide, please. Even as the COVID-19 pandemic continues, we are now confronted by a new virus, monkeypox. Today, we will hear from California State Epidemiologist Erica Pan, our frequent guest, who will give us updates on the situation with COVID-19, as well as the state's approach to monkeypox. Dr. Pan will be joined by Dr. Peter Chin-Hong, an infectious disease expert from the University of California, San Francisco. Dr. Chin-Hong will discuss the emergence of monkeypox as a global phenomenon, as well as the epidemiology, signs, and symptoms of this emerging disease. And this talk couldn't be more timely as Dr. Chin-Hong and his colleagues have begun to care for critically ill patients hospitalized at UCSF with monkeypox. So without further ado, and apologies for any sound problems we're having, let's dive right in and begin with Dr. Pan. Erica, take it away.
Great, thank you so much, Kim. It's great to be back again today and really fun to be with my colleague, Dr. Chin-Hong, who we trained with many years ago. I'm sorry, I'm still hearing feedback too. Let's see if that's any better. Okay, I'll try to keep talking. Maybe that works. Let's go to the next slide. Okay, so we're gonna talk this morning briefly about COVID and then move on to monkeypox. And, you know, again, we'll have a great integration of sort of the public health and epi perspective with Dr. Chin-Hong's clinical perspective and update you on what's going on with monkeypox. So next slide. Let's go ahead to the next slide. So this is the epi curve I show pretty much, you know, every time I'm here, and just to show you kind of an update on where we are as a state. This is really just the last few months, and the blue line is cases. So you can see we had a peak towards the end of May, and then we were starting to see a decline, and now we've been seeing increases again over the last few weeks. Will be interesting again to see there's a reporting delay, as you can see in that block. And of course, you know, the question always comes up as we're seeing more over-the-counter testing, how do these trends map? And this is just PCR as far as this blue line. But a lot of what we're seeing and the trends definitely seem to follow along with other supplementary surveillance like wastewater, et cetera. Thankfully, the red line here is deaths, and those continue to decrease. And we have seen very, very low levels of deaths. So I think all of the vaccination immunity is actually holding up for us in California. And then the orange line is, you can see a gradual increase here in hospitalizations, and I'll show you some projections on that. But thankfully, again, they are relatively low, certainly compared to prior surges, especially compared to the number of cases and the levels of transmission we're seeing. Next slide. And one other piece on the prior that wasn't on that slide, but our test positivity is up to 16% or so, and it's been relatively stable in the last week or so, but definitely at a high level for us. And so we're watching that closely too as well. And then for those of you that are following the CDC COVID-19 community levels, those get updated every week. And we do have about 40% of our population in the highest COVID-19 community levels. And these are derived from new admissions, percent of people in the hospital, and case rates and levels of transmission. So you can see the areas of our state that are in that high level, others that are in medium and low. So we're watching that closely as well. But as you see over the last couple of weeks, it's been relatively stable. We've seen some decreases happening in the Northern California Bay Area and Sacramento, but maybe some increases in Southern California. Next slide. And then this is you can also look at this on our website on CalCAT, but these are our hospitalization projections. And what our amazing modeling team does is look at a lot of different modeling, and then that deep blue line is kind of the compilation, or what they call the ensemble, which tries to bring together all those different models since they vary quite a bit. And if you kind of integrate all those, what do they see? And right now, looking like we could peak as far as hospitalizations towards the end of July, and it could be anywhere from around 4,000 to 4,500. Some of them project a little bit higher, but again, those have all been very manageable levels of COVID hospitalizations. And then the other thing that's not on here is that we're seeing in the data that we collect, about half of those hospitalizations might be kind of incidental, people sort of with COVID as opposed to being hospitalized for COVID. So they still take a toll on the hospital as far as infection control, staffing, et cetera. But again, nothing like prior surges that we've seen, especially with these levels of transmission. So really glad that a lot of our tools, including especially vaccines, are working. Next slide. And then, of course, the really important and interesting question right now is what is happening with these new subvariants of Omicron, BA4 and BA5, and how are they going to impact these projections? So we've been following this closely, of course, and we're looking at some of the states that had higher proportions earlier of BA4 and BA5. We are definitely seeing that these are more infectious subvariants, and how it's impacting hospitalizations. So California has actually been looking like, and our projections still look also like it would plateau, as opposed to some of the areas like Texas where it may potentially continue to increase. We're seeing probably about half of what is being sequenced is estimated to be BA5, and probably another 10 to 20% is BA4. So we're again monitoring that closely over time, and we expect that to be fully dominant. And definitely BA5 is much more infectious, probably some estimate 50% more infectious than the earlier Omicron, and more reinfections for sure as well. Next slide. And then I want to pivot quickly as a quick teaser and preview. Next month, we're actually really going to focus on pediatric vaccines, but as we are seeing more and more eligibility and authorizations for pediatric COVID-19 vaccine, I think a lot of parents still have a lot of questions, and I just want to again communicate as a parent, as a pediatric infectious disease doctor, these vaccines are safe and effective, and they are really effective at keeping kids out of the hospital and preventing deaths. We now have tools to prevent those, and our youngest children are actually the ones that have been hospitalized, at higher rates than sort of those middle ages. So really thankful that we now have this tool. And I think a lot of people don't know that children younger than 5 years of age, actually 5 times more hospitalizations during the Omicron wave, even though everyone said, oh, this is a milder variant. But more kids were hospitalized during Omicron than Delta. And about half of those kids, or actually more than half, as you can see here, were previously healthy kids. So again, this is a tool that can prevent hospitalizations. Next month, we'll compare to other vaccine-preventable diseases, but really important tools that we now have in our toolbox. Next slide. So on that note, I think you all know, and especially any of you who have kids under 5, probably especially know, as of June 20th, we now have COVID-19 vaccines eligibility for 6 months to 5 years of age. And there's a lot of questions out there about Moderna versus Pfizer. I think there's a few bottom line things. In other vaccine-preventable diseases, you're often not asking about the different manufacturer. I think they all have a successful immune response. They all have reduced risk of COVID-19 illness. There are no new safety concerns that have been identified. And any of the side effects post-vaccine in the clinical trials have been mild to moderate. There have been no deaths, no myocarditis. Acknowledging that these are small clinical trials, but these are the size of trials that we typically have for other pediatric vaccines as well. So the main differences are the dose schedule. So Moderna is 2 doses, Pfizer is 3 doses, and of course the dosing intervals. And we do actually, I think we in the CDC have been talking about, really probably depending on where you are, levels of transmission and risk, but those intervals can probably be a little bit further out, closer to 8 weeks between doses. So that's just sort of that. And again, we're going to have a big focus next month on pediatric vaccines, but wanted to just share that as sort of the bottom line is, getting your kids vaccinated, as soon as possible, getting your patients vaccinated with the vaccine available, and some of the logistics around that might be determinants of what you have in your office or what you offer to your patients. Next slide. And late breaking news from Friday is that we do have full licensure now for COVID vaccine for Pfizer for 12 to 15-year-olds. So that was a new development just in the last few days. Next slide. And then to highlight quickly, kind of a smorgasbord here today, but I think really wanting to make sure we continue to improve our awareness and use of therapeutics. So another really important tool that we have in our toolbox now. So we have oral antivirals. We still have a lot of gaps in equity. There was a recent MMWR on this, and we looked at our own test to treat sites in California, both federal, the federal ones are largely these blue boxes. I know this is probably hard to read on your screens, but you can see basically that there are large equity gaps. The bar on the far left corner is the least healthy quartile 1, and the one on the right is the quartile 4, the most healthy, most resource communities. And a lot of the other test to treat sites were, and a lot of treatment were happening in the highest quartile. So the yellow bars are the state test to treat sites that we have put out with our OptumServe sites in high vulnerability zip codes. Also, some important updates are that FDA did authorize pharmacists to prescribe Paxlovid with limitations. So that was a new authorization very recently. The pharmacists still need to get health records or contact the patient's regular provider to verify renal liver function and get a full medication list from the patient to track for interactions, and can refer patients to mid or high-level practitioners if that info isn't available or anything else is needed. But that is an important development to help improve access and equity. And Pfizer also has applied for full approval of licensure just last week, so we'll stay tuned on that. And then just a quick update on Evusheld is that there is new redosing information for Evusheld, just waning immunity like those of us with natural immunity or vaccine immunity. Evusheld also has had some waning, so patients should receive a repeat dose. Next slide. So now we're going to shift to monkeypox, and I'll turn it over to Dr. Chin Hong.
Great. Thank you so much for joining us. I meant to do this before, Peter, but I'd love to introduce you just before you get started. So Dr. Peter Chin Hong is a professor of medicine at UCSF and the Associate Dean of Regional Campuses. He specializes in treating infectious diseases, particularly infections that develop in patients who have suppressed immune systems, and directs the Immunocompromised Host Infectious Diseases program at UCSF. A member of the UCSF Academy of Medical Educators, Peter is a beloved and much lauded teacher. And during the COVID-19 pandemic, he's also become a frequent commentator and an informative voice, both for clinicians and the public, helping to keep us all updated on this disease. And now he's rolled up his sleeves to help do a deep dive into the new emerging threat, monkeypox. So Peter, please tell us what we should know. You're muted, Peter. Still can't hear you.
Okay, great. Now you can hear me. Great, fantastic. I'm always nervous about technology. I was telling Kim before I came on, but thanks everybody for showing up. This is great. We'll try to be as brief as possible. There's a lot of information to give a lot of time for Q&A. Next slide. So first we'll start off with just a brief background history. I think it's important to put this current outbreak into the context of decades of monkeypox outbreaks that have happened historically. Next slide. So first, a little bit of a virology. Monkeypox virus is a DNA enveloped virus, and that's important based on how some of the therapeutics work that I'll get to. It's different from, of course, SARS-CoV-2, which is an RNA virus. RNA viruses are generally much more fragile. They're kind of wilier. DNA is kind of like brute. It's stable. It's easier to diagnose, even with new technologies like next generation sequencing. There are lots of relatives of monkeypox virus. Of course, the most famous one we know about is the human version, which is smallpox. That's variola virus. It's very different because it was engineered to affect humans. So there's a lot more mortality in smallpox versus monkeypox. Monkeypox current outbreak, pretty much 0% in the developed world, about 5 or 10% globally. Most of that's occurring historically in outbreaks in West and Central Africa. Smallpox is the first disease with a vaccine that we can use, and it's the first disease that was eradicated. Other relatives, cowpox, of course, Edward Jenner, famous proof of concept for the vaccine. Vaccinia virus is the one used in smallpox vaccine originally. And then there's a whole host of other pox viruses, camelpox, horsepox, raccoonpox, skunkpox, bullpox even. So monkeypox is like a less deadly disease to humans because it wasn't supposed to infect humans. In fact, it should be called rodent pox because that's really where the sweet spot for this virus is. Next slide. So when you think about the history of monkeypox, it was first identified in 1958. It was seen first in monkeys that were infected, hence the name, even though it really, the reservoir is in small mammals, rodents, squirrels, etc., in West and Central Africa. There were these monkeys in Denmark, and then that led to this, actually one of the vaccine manufacturers, the main one is in Denmark, probably based on that history. In the 70s, we stopped vaccinating against smallpox, which does give partial protection against monkeypox because it's the same orthopox family, but immunity wanes. But military recruits still get vaccinated against smallpox, so they may have protection against monkeypox. But since we stopped vaccinating against smallpox, there have been more and more outbreaks of monkeypox, particularly in West and Central Africa, causing again about 5 to 10% mortality. Famously, in 2003, there was a Wisconsin monkeypox outbreak, and I'll have a slide coming up to discuss that in a little bit more. And of course, we've had sporadic cases of monkeypox, mainly in travelers coming to the US. This is the first time that we've had simultaneous outbreak in multiple countries that's outside the endemic zone. We don't know if it's because the virus has evolved or if it was all through social networks. So people are still trying to figure this out. This is a less deadly clade of monkeypox virus. There are two main versions. One that's West Africa, less deadly. One Central Africa, that's much more deadly. Next slide. So famous 2003 outbreak, important because when we think about stigma, it's not really about men who have sex with men, because when you look at the arc of monkeypox, it's really equal opportunity. In 2003, it was the pet owners of prairie dogs. It was a large outbreak in Wisconsin. There were 72 cases, multiple states, all had contact with prairie dogs, which are American species, but they were housed next to these Gambian rats, which were also pets at the time before they were banned. And they got infected, and then the pet owners handling the animals were all infected with monkeypox. So we got a lot of experience with monkeypox in the United States based on this outbreak. Next slide. So Erica is going to tag team with me and take it over with some epidemiology to tell you where we are.
Great, thank you. Next slide. So this just gives you a little bit of a flavor, and of course these slides are always immediately outdated as soon as you put them together, but just an idea of where we're seeing a lot of cases in the world and where the US is. So it is largely a lot of European countries that have in this 2022 epidemic that we're seeing. Next slide. And just to again give you kind of a snapshot of globally, you know, that prior slide was as of, you know, the 6th, and already as of yesterday, we have over 9,500 confirmed cases globally. There are 57 non-endemic countries that are reporting, so that European slide was just a few of those. 1 death reported globally to our knowledge. Then we're getting close to 900 cases in the US, in 36 states and territories. And here in California, as of yesterday, we have 148 cases in 14 local health jurisdictions. And I think, you know, we'll be talking a lot about testing and testing capacity over the course of this. This is probably just the tip of the iceberg. I think we're, you know, this is just those who are getting tested. Next slide. And to show you a little bit here, our epi curve here in California. So this was as of last week. And again, you can see the gradual increase in cases that we're detecting and reporting. The risk factors here in California, and this has been pretty consistent with a lot of those other countries noted. Initially, some international travel, including noted sexual contact in other countries, close or intimate contact with a known monkeypox case. There was even one case that was sharing clothing. And that was the reported exposure. And in general, this is really a skin-to-skin or close intimate contact. So Most of our cases have attended large events or venues with noted skin-to-skin contact and or multiple sexual partners, or again, been a close intimate contact with a known case. And again, as highlighted, we want to really emphasize this disease can impact anybody, but it has really been in these networks that really have been global. And in California, we have had all male or transgender male cases to date. And thankfully, hospitalizations continue to be rare, both in the US and globally. Next slide. And then here's what's really interesting and somewhat concerning, actually, is that we are seeing monkeypox now in our wastewater surveillance. There's actually only a few sewer sheds that Stanford has actually got an assay that has a very low level detection. But you can see here we've had multiple positives in a couple areas in San Francisco, and then there have been intermittent detections in San Jose and Gilroy, near Davis and Sacramento, which is the newest place. We don't know yet about that same assay if it were applied in other sewer sheds around the state or even around the country. This is the first detection of wastewater that we're aware of in the nation. But again, this really implies that there's a lot more disease there than we actually realize. So that's why a lot of our other approaches that we're going to talk about are really important to stay on top of with the resources we have. Next slide. So I'll turn it back over to Peter for the clinical.
Great, thank you, Erica. Next slide. So this was the first case reported in New England Journal in the United States. It was, of course, at Mass General Hospital. It was widely reported in media and really illustrates, I think, some of the non-textbook presentations that we've been seeing in this outbreak. So it was a 31-year-old male who presented with severe rectal pain and lymphadenopathy, found to have perianal lesions and proctitis. Also had scattered lesions on the trunk, legs, and hands, and diagnosed with monkeypox due to the fast thinking of the team. It wasn't seen in North America at the time. They had read about it, and they worked with the CDC to do the PCR testing. You can see in the pictures two of the real classic sort of fluid-filled blisters that can happen with monkeypox. Of course, could look like anything else as well. But to me, it's the movement of the rash, and I'll get to that. That's the clincher for clinical diagnosis. And then when you look at its rectal area, there's a lot of inflammation and discharge, very extensive disease in this patient, and that can be very, very uncomfortable. Pain is a big hallmark of symptoms of the patients. Some patients say it's like the worst thing that they've ever had, and they don't even really care about the rash. It's the pain that really keeps them up at night. Next slide. So you get exposed, and what's good, but also what's bad from a contact tracing and disease containment perspective is that the incubation period is relatively long. It's a little bit shorter than the textbook for the classic cases, but it's on average about 7 days, the range of 4 to 11 in the first report of cases from the UK reported. Then after that, you have flu-like symptoms, but not everybody has flu-like symptoms. So about 20% of people have absolutely no symptoms, and they start off with a rash. The top 5 symptoms are fatigue in more than 70%, fever, more than 70% again. Lymphadenopathy is very unique with this illness, myalgias and sore throat. So for some people, it might feel like COVID. In that prodrome, it might feel like a cold or flu, but then the rash happens in 100% of people, probably about a day or two after the flu-like symptoms, if you get it. Sometimes people just get with the rash first. The rash is really interesting. It's not like the textbook again, where it starts off on the arms and then moves around the body or on the face. It starts in the anogenital area. It might look like herpes or syphilis or a boil or a staph infection an initial stage, or you might not even see it if it's in the anal area. Not many people have been hospitalized. Today at UCSF, we actually have 2 patients hospitalized. I can talk more about them, but 2 other patients, most of the patients we've heard about or seen have been outpatients. So the vast majority do quite well. When they're hospitalized, it's usually for intractable pain, pain on overall pain on bowel movements or concomitant diagnoses. And I think as sexually transmitted infections, 25% of patients, certainly borne out in our cases, and UCSF, probably 50% of the patients we've seen so far have had another STI. The most dramatic one was Somebody coming in last night actually had secondary syphilis, was treated, had a Hirschheimer reaction with this big rash all over the body, but hidden within that rash was monkeypox lesions. The ID team saw the monkeypox rash, sent the diagnostics, and that is how patients are presenting. So having an STI is not, it's not like just you found out that it was syphilis, so it couldn't be monkeypox. It could be both at the same time. In fact, in a lot of cases, it's both. Next slide. So some of the rash pearls are, it follows the flu-like symptoms. Pretty much 100% of people get the rash. It may start in the genital area and may be very subtle and may be confused with other things, like I mentioned, like syphilis, folliculitis. We had this patient, heard about this patient in Kaiser, where the patient presented with looked like a perianal abscess. So the provider was just like INDing it, and then lo and behold, happened to send a monkeypox DNA, and it turned out to be monkeypox, so the provider had to be vaccinated. So I think being very, very cautious, and in this current era, thinking anything can be monkeypox, you know, within suspicion is probably a good idea. And as I mentioned, the movement of the rash is the key diagnostic clinical criterion or pearl, because it may just be a staph infection or something, but if the patient says, hey, it started off in the genital area, then it moved to my arms and face and mouth, well, that movement and the kind of rash starts off maculopapular, then vesicular, fluid-filled, maybe have some pus in it, and then scabs off and falls off. That's really the way that the rash moves. The rash can be umbilicated, so it has a little dimple inside a lot of times. Again, pain is really, really prominent in many people, and really prominent is rash in the palms and soles. So we learned about syphilis doing that, Rocky Mountain spotted fever, phase step 1 on boards, but monkeypox is definitely one of those as well. Then it crosses over, scabs, and falls off in about 1 to 2 weeks. The whole illness course can last about 3 to 4 weeks. So again, it's kind of like you know, a big deal for patients to get this because they're out of commission, and Eric can talk more about the infection control aspects, but they really can't be considered non-infectious until that rash scabs off and they don't have any more active lesions. Next slide. So just a little bit word on diagnostics, and Erica can talk more about the way the California response is. Next slide. So the main diagnostic is a PCR. When you suspect monkeypox, we treat it like novel virus precautions. So masking with N95 from a provider point of view, gloves, eye protection, and gowns. I wrote gloves twice, but I meant gowns. Just because of that surface possibility for transmission. So you don't want it to get on your clothes. 2 swabs for lesions. Try to swab as many lesions as possible. We had this patient who got a false negative. He had like classic monkeypox. That's because in initial clinic, they only lightly swabbed it. I know as providers, we don't want to cause pain. These lesions are very, very painful. So it's like, you don't want to really swab it hard. Patients saying, ouch, ouch. But you really have to get fresh tissue to really increase that yield of PCR. The CDC says you don't have to unroof lesions, but really, if you can take a scalpel and lightly take off some of the crusted lesions, if they're too old, that will increase your yield as well. So again, you want to get like fresh skin, not just like the skin that's not painful or dead. Use a sterile container, dry, or use viral transport medium with that black top. A lot of clinics have it. If you want testing by DPH and CDC, you need prior approval, but increasing commercial labs are also doing it using the CDC assay like LabCorp a few days ago. Next slide. I'll talk a little bit about treatment. Next slide. So there's a treatment that's available called Tecovirimat. It's also called Tpoxx, which is kind of an interesting trade name with 2 X's. It targets the envelope of the DNA virus and prevents onward replication and infection of other cells. It's available in oral as well as an IV in kids. You can like mix it with food. It's 3 pills twice a day for 2 weeks. It's FDA approved for smallpox in 2018, but not FDA approved in this country for monkeypox or other members of the family. But we can use it under expanded access IND from the CDC which we've been using for monkeypox. Patients need informed consent. You need to have your local IRB involved, as well as the CDC has a parent IRB, and it's available from National Strategic Stockpile. But there are other drugs with activity but limited by toxicity, including cidofovir, brincidofovir, renal toxicity, and there's even immune globulin for severe cases. We haven't had to use immune globulin yet, but the CDC has it. Next slide. So who do we treat? Well, not everybody. The vast majority of people won't need treatment, but I break it down into two boxes. Either they have like really bad disease or they're bad hosts. So the bad disease in particular is people with like confluent rectal lesions. And the reason why is because it's extremely painful to defecate. They have like bleeding. It's really, really tough. Or extensive oral lesions where it's difficult to eat and drink, or lesions near the eye because it can cause problems with vision if monkeypox gets affected in the eyes. And of course, people in the hospital in general might have superinfection, sepsis. Like any rash, you can have bacteria get in and cause sepsis. So I think those are the criteria for the bad disease. And then bad host, any severely immune compromised individuals, kids under 8, pregnant or breastfeeding persons, inflammatory bowel disease, because it just with the bleeding and inflammation can make strictures and things worse for that patient, and severe and active dermatologic disease like bad eczema or some of these cutaneous T-cell lymphomas and stuff like that. You may want to also treat these people just because they have all of that going on and may change the immune milieu. Next, so on these pictures is one of my patients who agreed to have his pictures shown. Really on day 3 of therapy. He had it everywhere. I'm just showing you 2 representative pictures. He was in the bad disease category, all over his rectal area, near his eyes, and you can see the rash on his palms. He also rashed on his soles as well. And then by day 3, it was completely starting to clear up. Right now, it's pretty much all gone. Next slide. So this is what some of the patients said. I feel neither need to what I was experiencing this weekend. Actually, since the day after UCSF, that is the treatment day 0, I didn't need to take any painkillers even to sleep. Prior to that, I had trouble sleeping even more than an hour at a time. New lesions have stopped appearing, and all the ones on my body and face seem to be healing and peeling. Yesterday, it was still difficult to walk, but today I can walk at a semi-normal pace. My hands and toes just feel numb, but I assume that's due to the coat of dead skin on them. I fear especially how this will impact the most vulnerable amongst our community. I'm highly privileged, remote worker, high earner, ample paid time off, with partner who can take care of me and no dependents. I was completely debilitated, but got through okay. I can't fathom the damage monkeypox can do to a gig worker or a single parent. Next slide. So Erica will then take the baton to talk about prevention.
Yeah, thanks so much for sharing that patient experience, and just a couple other tidbits about both the labs and treatment. As far as it is still, because this is sort of a re-emerging or novel disease in the United States, these resources are only available initially through the public health lab networks. As far as testing, there were 10 public health labs that are able to do orthopox testing in California. And as mentioned, really grateful now that LabCorp is on board now to do testing. Mayo Clinic as of this week. There are a couple others that are on the docket to be added as well nationally, which California providers can be sending to. So there's going to be increased capacity for testing moving forward. Some of our academic partners are starting to do this as well. I think Stanford is also testing for monkeypox. And then as far as treatment, again, as mentioned, this is available through the Strategic National Stockpile, similar to the vaccines, which I'll talk about in a moment. So your provider needs to work with the local health department to order that. And then because it's an IRB and IND protocol, there's a lot of paperwork involved. So right now there's 4 or 5 sites that are currently able to do this, and a few more in Northern California versus Southern, but UCSF, San Francisco General, UC Davis, and Kaiser Northern California is now up and running, I believe, to give treatments, and then Cedars-Sinai in Southern California. And again, over time, I think more and more centers will be able to provide the treatment, the Tpoxx treatment. And then just to talk about prevention for a moment, as far as outreach, we've been really working with a lot of important partners to get input on messages, really want to increase awareness. So really talking to sexual partners and intimate contacts about, if you have a rash or if your partner has a rash, really thinking about it and having it on your radar and really getting tested and getting checked out if anyone does have a rash. So we have a lot of these co-branded flyers. There have been some paid ads on Meta and Grindr. So continue to work with our various partners to work on outreach, specifically, again, to the population that's been impacted the most so far. Next slide. And then, so everyone's, how much vaccine is there? And we really do think, I think because of the difficulties in trying to find all contacts, we really want to emphasize sort of using vaccine both for post-exposure prophylaxis or prevention, and then eventually for pre-exposure prevention like we typically use vaccine, but it's really a scarce supply right now. So Jynneos vaccine is one of the newer vaccines. There's only, in phase 1, there were only about 56,000 doses nationally, and this is actually a 2-dose series, although we're really talking about potentially, and it's typically 4 weeks apart, but again, there could be a delay in that with really good, pretty good immune response with that first dose. So this first phase, total in California has been about 19,500 doses. LA actually receives and distributes their own allocations, but that's the total there. We've allocated to the local health departments based on a formula which basically weighs the number of reported monkeypox cases, and also the other half of the formula has been as a proxy for the highest risk populations, early syphilis in males. So we have allocated that. There's a lot of great work happening to get to identified contacts, people exposed at certain venues where there's been associated cases. And then just this week, we have been able to order and should receive very soon another 25,000 doses here in California. LA will get their own allocation as noted here, and then close to 15,000 for the rest of the state. So we're working on that allocation formula. We'll be getting that out this week. And again, hopefully we'll have that next phase here soon. To be nationally will be another close to 100,000 doses nationally. We don't know yet what the California allocation will be. And then phase 3 will probably not happen until September or so, is when there will be anywhere from 800,000 to 1 million doses nationally. So unfortunately, a very, very scarce resource right now. And then our understanding is the federal government will order another 3 million doses, towards the winter and early 2023. So this is difficult, and we really have to focus and prioritize how we're using this vaccine. Next slide. So right now, the priorities really are people who are known close contacts of cases, or what we're calling expanded post-exposure prophylaxis. So this is attendees of events or venues where known monkeypox exposure has occurred. There are definitely, some specific pride events or bathhouses that have been associated. So we're really working with local health departments and other CBO partners to get vaccine to the highest risk individuals in those settings. And then there has been a little bit of vaccination as well for some of our lab workers, healthcare workers, like Dr. Jin Hong mentioned. Those are kind of our focuses right now. And then as we get more vaccine, I think we can really try to open up to more individuals that are potentially at high risk for kind of more pre-exposure prophylaxis. Next slide. And actually, the last thing I'll just say about vaccines, just to mention it, and I didn't put a big focus on it, there is an older smallpox vaccine called ACAM 2000. It's the one that some of you may have gotten if you, we stopped doing smallpox vaccine probably in around like the late 60s, early 70s was really the latest, and it's a bifurcated needle. It uses vaccinia virus, so you can actually still shed that virus. And so if you live with someone who's immunocompromised, you can shed that virus. There's also more side effects from that vaccine, and actually the efficacy data on Jynneos is much better. So when we look at kind of the severity of the monkeypox disease and the risk benefits of vaccines, Jynneos is really a better vaccine, but again, in limited supply. But that's really why we're emphasizing, and glad to see that more Jynneos vaccine is coming. So I will turn it back over to Peter. Thanks.
Great. So we'll just close on just saying there are probably 4 scenarios for what we're seeing right now. I think because the disease was much harder to recognize in this current outbreak that took everyone by surprise, it means that the infected people couldn't really stay away from the uninfected people, and that's why we're seeing a lot of transmissions, and there's in the wastewater right now. So I think it's probably hard to imagine that it will be a self-limited outbreak, but it's still possible with all of the efforts of all of us. And that means that it will go away and it'll just be sporadic traveler-related cases, and then remain endemic in West and Central Africa. So that's scenario one. Second scenario is that with this current outbreak, it bleeds over into the general population. I think the population that'll be most at risk will be those under the age of 50 who don't have any immunity from smallpox vaccine, which was stopped in the 70s, possibly. So it'll be the opposite of COVID. But again, we don't really know how that will be. And then maybe it will burn out and then it will go away. So that's scenario number two. Number three is that it gets into some animal reservoir in the United States, like rodents, prairie dogs, what have you. Again, it's trying to find a mammal. It's like a small rodent, not really a human. And if it does get that, it becomes endemic. So it'll be something that we have to worry about every time somebody comes in a rash. It's like herpes, syphilis, monkeypox in the clinic. So that's the way it will be endemic. And then when it becomes endemic, scenario four is that it can then cross from animals to humans occasionally and then cause these outbreaks like we're seeing right now. So I know it's not like super encouraging, but again, it's very different from the early days of COVID, where we have diagnostics, we have vaccines, we have therapeutics. It's just a matter of, I'm hoping and crossing my fingers that it doesn't become endemic. Next slide. I think with all of that darkness, we should reflect on this slide that was given to me early on in training by one of my mentors, and it always kind of keeps me grounded to everything. My butt hurts, and then the other bunny says what? I use it for Easter in particular, but I think it's a good time to show it again. Next slide. So I think Eric and I can answer any Q&A now, thanks for your attention.
Thank you both so much. This is such good information and a time where we're all craving information, and we have loads of questions, both on the COVID side and on the monkeypox side. Just before we get started, I will remind everyone that the PDF of these slides is here and available for you today, so you can download that and keep it for your reference. We always do that. And then I also just wanted to mention that there are a lot of questions, particularly on vaccines and boosters for COVID. And we have a national infectious disease vaccine expert next month, Dr. Paul Offit from the East Coast, and we're really excited to be with him. So we're going to talk not only about pediatric vaccines, but also about the next versions of boosters that are coming out in the fall or that are expected to. So we'll hold off on a lot of those questions as well. I'm going to dive in right now on some of the monkeypox questions, since that's super top of mind for us all. Peter, maybe you can help us understand a little bit more about transmission of monkeypox. So, we've been reading it's airborne, but it feels like skin-to-skin contact maybe is important. And then also, can you talk about that? And also, do we have a sense of what the infectious period is? Do you have to have lesions to be infectious? Are you infectious before you get any symptoms?
Yeah, so I would say that this is in the middle of evolving data for this outbreak. So what I'm going to say now is just really based historically on what we know so far about previous outbreaks. But again, things may be different. So right now, I think about risk in terms of a scale, right? Anything is possible, but probably the most risky thing is really, as Erica pointed out, skin-to-skin contact with somebody with a lesion, an open sore. That's probably the most efficient way, and time. So again, the monkeypox virus isn't trying to find a human. It's like trying to find a rodent. It just happens to be in a human. So it needs a long period of time. So that's why so far in this outbreak, people have been together. We think most people for a period of time more than 3 hours, 36 hours or longer. So skin to skin time. It's been found in semen in one study, but not all samples of semen and not all the monkeypox virus is viable. So it is possible that it's also sexually transmitted in the way we think of an STI, which is through semen, bodily fluids, etc., but not the primary. Lots of people got it without actual sexual bodily fluid contact, possibly. So that's kind of the lowest hanging fruit. I think, again, duration, you're in, there's some viable virus on the bed sheet and you're there for like 3 to 6 hours, possible to get it there. And then it comes to the other things that I think a lot of people are anxious about, like being at a rave and somebody's like 5 million feet away from you and they told the rave owners or the event planners that they got monkeypox, I think it's very unlikely that those people will get monkeypox. But again, it's possible, particularly if you're there for a long time and you happen to be in contact with them, even skin to skin, for a long period of time. So the point is you can't really know who's next to who in an event. So hence the recommendations from public health. And then in terms of like respiratory droplets, sure, it's possible. But again, it's duration of period of time, not 15 minutes like COVID. Again, 3-6 hours next to somebody, right up close and personal. Droplets, airborne, really little evidence for that so far. So that's the hierarchy of risk that I think about when I talk to patients. And again, like everything, you navigate risk not knowing something is 0 or 1, but that there's some things that are higher risk and some things that are lower risk.
Yeah, great. That's super helpful. And then, just in terms of the clinical presentation, I wonder if the anogenital rash is something that has to do with the specific nature of contact and the population in which it's changing. Just because I know we have implicit bias in everything that we do, are we going to only look at this and think monkeypox if there's, anogenital rash now? So do you think that if this does transmit to a broader population, maybe the presentation will start to be a little different?
Yes, definitely. In fact, in the classic monkeypox region, outbreaks is not in the anogenital area. In fact, people are looking for the, we always see the same picture in the media. It's the child with the big sort of bulbous pustules everywhere. I think that it could possibly be where the person first got contacted. That's where the first lesion typically is. So like in the pet owners is where the prairie dog bit the pet owner, or where they were cleaning the cage and then the animal bit, and then that's where the rash started, and then it moved to other parts of the body. So I think we have to be on the lookout as clinicians to any possibility, but also not be panicked. And also, I think it brings up a good point about stigma, because again, this is not an MSM disease. And the fact, if we're like anchored to the idea that everyone starts off with an anogenital rash, it also means that not only the hate and the stigmatization, but also people who are not MSM wouldn't always necessarily think of themselves at risk, or you wouldn't as a clinician think of them as risk if they haven't had this traditional contact.
Right, great, thank you. And what about pediatrics? Have we seen any pediatric monkeypox in the US, California, and the world?
Definitely not in California, and I don't think in the US either. But I will say, just like looking at some of the fatality rates that were mentioned earlier, that is where the highest mortality has been young children in Africa. And sometimes the thought is maybe like sepsis or superficial bacterial infections, super infections. So I think, but so far, no. I do want to, one other thing though, just to thinking about the future and what we're like kind of looking at too, is what has happened with syphilis, and really unfortunately, seeing early kind of increases in MSM, and then how that's now increased our congenital syphilis over time. And so that's something we really want to avoid, because this also can be a vertical transmission disease, and definitely has bad outcomes in fetuses. So that's something we're really, again, why we want to be as aggressive as possible, but with our limited resources.
Okay, great. Actually, and Erica, your answer brought up a question about mortality. So just to fully understand, because we know that there are people who have died from this disease, is the mortality largely from a secondary bacterial infection, cellulitis, sepsis, those kinds of things, or what else do people die from with this disease?
That is my understanding, and Peter, feel free to add, but that's my understanding. That's largely what's been the biggest mortality.
Yeah, that is my understanding, definitely. I mean, the skin, the largest organ in the body, etc. It's just like a burn patient if they have really extensive lesions.
Okay, great. And there are lots of questions about access to testing, treatment, and vaccines. So I know that any information the state can provide over time and in a large way to clinicians, maybe through CMA, will be super helpful. But one question that we had is, how long is it taking the lab tests to come back?
Yeah, and that's definitely very variable. So again, across California, there's about 10 public health labs that are doing testing. Some of them are doing them Monday through Friday, some 3 times a week. Some are doing 7 days a week still. I think it is, again, great that these commercial labs are starting to do it, but even those, they're sending, all the specimens to, Minnesota or the East Coast. So it definitely can take, 2 to 3 days, I think. It's not an immediate test.
Okay.
I guess one follow-up comment on that is that, the CDC and the state does not require you to have a positive test in case somebody has severe disease. You can start treatment if you can get access to it before you actually have a defined diagnosis. And that really is to break down that barrier for people who might need treatment.
Okay, super helpful. And on the treatment side, it really does sound like that you need infectious disease consult. You really need expert access in order to get treatment right now. So you'd go to a center that has really great specialty care. Yeah.
Yeah. So the way it works practically is, not everybody has treatment right now. So I think hospitals can talk to each other for the sickest patients to transfer them. And that's what happened in a couple of patients at UCSF, for example. They came from another facility that didn't have the capability of the IRB and the consent and all that stuff. And UCSF agreed to accept these patients, and that's how they got treated.
Okay, so just to understand that process, the IRB approval is given to an institution, and then patients within that institution can be treated at the behest of the experts there, or whatever.
Yeah, so it's actually simpler than that. The CDC has an IRB, so it doesn't have to go through the 6-month period in a local IRB. The local IRB just has to be aware that that's happening, and they may just need like a list of like who are the people going to give consent or something like that. It's a very quick process. But I think just huddling with your local IRB to know what their requirements are, given the fact that the CDC has the central IRB, so you don't have to like go through that whole process with data and all of that anymore.
Got it. But this is clearly not something that a practitioner in an outpatient office is going to be doing for at least for now.
Okay. I mean, one method that has worked in San Francisco is that some smaller practices may partner if they're part of a network with one members of the group that has the IRB, so that they can check off, okay, the IRB is at UCSF, but we'll do City Clinic and we'll do San Francisco General, and so it will apply to other institutions, even though they're not exactly the same. So that might also work for some people.
Okay. Moving on a little bit to vaccination, there are a lot of questions from people who have had themselves smallpox vaccine, and you alluded to this before 1972 or whenever it was we stopped giving it. What do we know about immunity of those people? You suggested that we hope and suspect that they will not be as susceptible, but do we have much data on that?
I think we don't know. That's why Erica and I are so quiet. I was hoping Erica would say something, or if I said something, I'd hope Erica would add to it. But I think we are not going to bank on that as a primary immunity in this particular outbreak. But if somebody had that smallpox vaccine, they're probably going to have a little bit more protection than the general population, but we can't tell you for sure. Or if they do get disease, maybe their disease will be milder.
Yeah, and I think I would just add, there are many cases who have been vaccinated, and I think there is speculation, as Peter said, that maybe they're having milder disease, though. I don't think we have any hard data on that yet. And there's some speculation, though, too, that maybe this increase, because there has been, and Peter had a nice outline of the timing of some gradual increases in sporadic cases and/or outbreaks over time, and there is some speculation that maybe because of that, sort of the combination of waning immunity and/or not having that vaccine anymore might be why we're seeing more over time. Because but I think we have a lot more studying to do on this.
Yes, so much to learn. Speaking of studying and learning, I don't know if there's any sense yet about, but people are asking if we have a sense whether monkeypox is evolving or mutating already as we begin to see it spread.
I can speak to that, or at least start. I think, thankfully this is a DNA virus, so it's much more stable. It is not something like, SARS-CoV-2, which is just rapidly changing. And we do have, and it's nice, actually, we have more robust whole genome sequencing networks now too, thanks to, some of the silver linings of COVID. And we're not seeing a lot of changes. And I think to also emphasize, we are seeing in this 2022 epidemic is really largely this, it is all actually this Western clade, which is the less serious version, but we're not seeing a lot of mutation. And again, it's one of the big distinctions between a DNA virus versus an RNA virus.
Great. Okay, so this is all super interesting. We have 3 more minutes, and I think I'd like to dive back into a couple of COVID-specific questions for this last minute. And specifically, a lot of people have questions about the oral meds. We've talked about before about how as COVID does evolve, the oral meds, some of them have become less effective. And so can you comment on the effectiveness now of Paxlovid on current strains? And then also maybe talk a little bit about Paxlovid rebound. We're seeing Anthony Fauci even talking about this. Should this be a consideration when prescribing it, or we just prescribe it and let patients know this is a possibility?
I'll start briefly, and I'm sure Peter has a lot of direct clinical perspective too. I think, first of all, what we'd really been losing a lot of was the monoclonal antibodies because of the changes in the spike protein, but Paxlovid works in a very different way. So, you know, I have not seen any data saying less effectiveness against the newer subvariants. As far as the rebound, there's a really great study that came out of Southern California recently showing a very small proportion, you know, 1 to 2% of cases treated have this sort of rebound. And that's part of the natural course as well of SARS-CoV-2. Even early in 2020, we saw this sort of bimodal. I do think there's some, you know, studies going on, should we do 10 days versus 5 days? And I think that'll remains to be seen. But the bottom line is it is keeping people out of the hospital and preventing deaths. So that's sort of my perspective, and I'm sure Peter has more to add to that.
Yeah, so there are 2 flavors of rebound. One is where the person just tests all the time and they're actually feeling better. I've seen that flavor a lot. That's actually the majority. And then the test turns from positive to negative to positive. Then there's the other flavor where they might get that sore throat back again. But in all the cases I've heard about, it's milder. And some people also suggest, well, hey, maybe you're starting off too soon after diagnosis and maybe you give it a day. You know, that's speculation as well. But like Erica was saying, it's really remarkable when you actually look at a more systematic study. It's not as anecdotal thing, you know, when somebody posts on Twitter, how many of you got rebound, and like Bob Wachter, like 60% responded. And like when you look at the studies done more rigorously, it's like 1 to 2%, which was a trial. And like Erica said, remarkable to know that it also happens in people who don't get Paxlovid and where you can have recurrent symptoms.
Great. Well, that is why we're so incredibly grateful to have you here to help mediate what we're seeing and trying to learn from the media, and also really help. You guys are so on top of both the clinical picture in your own practice, Peter, and in the studies. And so we're really incredibly grateful to have you today. Loads more questions we could ask, but we're going to have to close up. For everyone, just to remind you, you can download the PDF right here. This presentation will be on YouTube very soon, and so you can send colleagues, friends, and neighbors to it for spreading this information. And our next session will be on Tuesday, August 9th, and the information on that will be at covidroundca.com, but it's a very exciting session with Dr. Paul Offit talking about vaccines broadly, specifically also pediatric vaccines. And if you want CME, do complete your survey. That'll be sent out at 5 p.m. today. And we'll, in that email, we'll also have instructions about how to access the recording. Thank you so much, Peter and Erica and all of the attendees, and have a great day.
Thank you. Bye-bye.